It Out Loud, a podcast by Chasing the Rainbows with your host, Bernice Quisenberry.
Today's episode of Cry It Out Loud is one that so many in our community have been asking for, a deeper conversation around recurrent pregnancy loss, infertility, and the medical questions families are often left searching for answers onto their own. For parents who have experienced miscarriage after miscarriage, loss after loss, the grief is devastating, but the uncertainty can be just as painful. Questions like, why did this happen? Was it genetics, hormones, the embryo, my body? Will this keep happening again? Too often families are told it's just bad luck or to simply try again, but recurrent pregnancy loss is complex, and many parents are already doing deep dives trying to understand the science behind what they've experienced. That's why today we are joined by Dr. Ryan Martin, a board-certified reproductive endocrinologist and infertility specialist with Shady Grove Fertility. Dr. Martin earned his medical degree from Yale University School of Medicine, completed his residency at Yale New Haven Hospital, and went on to complete his fellowship in reproductive endocrinology and infertility at Yale. His work focuses on infertility, IVF, genetic screening, and helping families navigate complex fertility challenges. Beyond his medical expertise, Dr. Martin's story is one of incredible perseverance. After a tragic injury at age 12 left him paralyzed from the waist down, he went on to become the very first wheelchair-bound graduate of Yale Medical School, dedicating his life to helping others beyond their families. Today, we're going beyond surface level conversations and diving right into those real questions lost parents are asking about genetics, embryos, sperm health, uterine factors, why early term baby loss can still happen even when everything appears normal. Dr. Martin, thank you for joining us and for helping our listeners better understand the science behind recurrent pregnancy loss while honoring the grief so many families carry.
Yeah, happy to help. Hopefully I can answer any questions that might help you get through all this.
Absolutely. Well, thank you. We'll dive right in because we got a lot. We did hear you listeners. We appreciate your feedback, things that were submitted. And yeah, we'll go right into it. So medically, recurrent pregnancy loss, RPL, is often defined as 2 or 3 consecutive miscarriages. Do you believe we're waiting too long before doing a full evaluation, or should parents be offered testing after 2 losses instead of 3?
Well, traditionally it was 3 losses. That's like the old definition of it, like start to evaluate after 3. Yeah. But most of us, including me, thought that was a little crazy to say, well, after 2 losses, we're not going to check you. Wait for 3, but we don't really do that in practice nowadays. We start to really check it after 2. If you have 2 in a row and, there's things that we can look at to start an evaluation to try and decrease the chance of having a 3rd, then we should definitely do that. And so almost all of my patients, really, it's that early that we see them. And sometimes people come in at 2 and say, I don't know if I'm here too early. And I say, no, you're here at the perfect time.
That's great, Ryan, just to be able to go in to, feel validated in their losses too, because I know like 1 feels like a lot, and then 2, and it is devastating. So having a, person who understands, a provider to go to and to turn to, who takes it with such care.
Yeah. I mean, to come in and say, well, we're really not going to do anything to you have another one is like a terrible thing to say and a terrible thing to hear.
Isn't it?
So we don't do that.
Yes. Oh, I feel that so much. Thank you. We're often told a miscarriage was due to a chromosomal abnormality or bad luck. Can you explain the difference between a random genetic error and something inherited like a balanced translocation? And when should parents have karyotype testing to check their own chromosomes? It's hard to hear unexplained. And a lot of times we don't get those answers, especially in the early term losses.
Yeah, so this is a great question. I answer these types of questions every day. And so one of the things that we think about is, all right, well, how do we know that pregnancy losses are related to abnormal chromosomes? We refer to that term as aneuploidy, an embryo that has the wrong number of chromosomes. We know that because when people have D&Cs or have surgery to take pregnancy tissue out, 2/3 to 3/4 of the time, we find that there's a genetic abnormality. Now, that can change based on a woman's age, but the general idea is we see it often enough to know that that is a major cause for losses. So what happens is they do some genetic testing on the products of conception, and lo and behold, we find there's the wrong number of chromosomes. There are a couple ways that that happens. One of the ways that we think that happens most often is related to eggs. And a lot of that has to do with biology, meaning women are born with all their eggs, men make sperm all the time. So eggs used to get pregnant are the age of the woman plus, eggs were made when they were 20 weeks in utero, right? So if you're 36, the age of your eggs is probably 37. Yeah. And whereas sperm that is used to cause that pregnancy is about 90 days old. So there's a lot more biologic complexity to eggs than there is with sperm. And so what often happens is women ovulate an egg that happens to be genetically abnormal. Most of those eggs don't fertilize, but sometimes they do. And when they do, chromosomes. The embryo starts to implant into the wall of the uterus, does the things that it needs to do, and then stops when it doesn't have the next information to do the next thing, like grow a heartbeat or whatever it is. And so that's the main etiology for losses from a genetic point of view. Sperm also play a role, and I think you'll probably ask me some questions about it later, but sperm also plays a role in aneuploidy as well.
Yes.
But in general, from a biologic point of view, that's the case. Now, that is someone with a normal genetic makeup. Two parents with a normal genetic makeup can have these aneuploid embryos. It's a random event. Now, you asked a question about whether or not there's a parental contribution to having losses. And one of the genetic things that we think about related to that is something called a translocation. A translocation is something that you can be born with that has no health implications and shows up solely as recurrent losses. And you can sort of think of it like our chromosomes are like an encyclopedia, a set of encyclopedia books when we used to have those.
Yeah.
And they're supposed to be in order, and you're supposed to have the whole book, and they're supposed to be in order. Now, you could be born with an abnormality in the order of those chromosomes, or whether or not you have a whole book or not. And that's called a translocation. So pretend we're reading a book and it's 10 chapters, and chapter 10 and 5 are switched. So we're reading chapter 1, 2, 3, 4, and then chapter 10. So the book's now out of order. Book's going great, but it's out of order. Yeah. We have the entire book, so we have all the information we need, but it's out of order. The same thing can happen with your chromosomes, and we refer to that as a translocation. When I talk to my patients about this translocation, it is an out of order book.
Yeah.
And basically what that means is that if a woman has the balanced translocation, then you could have more abnormal eggs. If the man has it, then you could have more abnormal sperm. And so when they get together, they make embryos that are abnormal and lead to losses. And so part of our standard workup is to do karyotypes on both parents to try and see if they have a translocation. As part of our standard loss workup, that's what we do. So after 2-3 losses, when someone comes into me, this is part of the things that we look for, because it's about 2% of the time in recurrent losses that we see something like this, but it's a really bad thing to miss. So is there something we can do about it? And so checking for that is super important.
I love how you simply put that with the chapters being out of order, because it makes so much clearer sense, than sometimes the medical way of describing it. So thank you, Ryan, for that.
Sure.
Yeah. And what's interesting? So yes, focus a lot on, eggs. With my husband and my secondary infertility journey, a lot of it was, me. It was me. And so, yeah, it's interesting. So I, never really had to have the conversations around sperm health, But, with you mentioning that, how significant is sperm, DNA fragmentation and recurrent pregnancy loss? And when should couples consider advanced male factor testing?
So this is a controversial subject, and probably a reproductive urologist is going to answer this in better ways than I can. But the general idea is that we do know that sperm contributes to recurrent pregnancy loss. And we know that for a fact. That I don't think there's any ambiguity about that.
Yeah.
But the question is, what do we do about it?
Yeah.
So the idea is that sperm can have DNA that's a little bit fragmented or abnormal, and that can happen as the sperm is in the testes, as opposed to part of it's how it was being generated. So it has to do with like the storage. How long is it being stored and creating this oxidative stress that leads to fragmentation of the DNA? Yes. This then in turn could lead to an abnormal sperm fertilizing an egg, making an abnormal embryo, leading to aneuploidy, what we've been talking about, the wrong number of chromosomes. Yeah. Now, in general, we don't really test DNA fragmentation unless there's an abnormal sperm count, as a general rule. There are times where we can certainly test DNA fragmentation, and certainly can do it with recurrent pregnancy loss, but it's not part of our standard testing, because there's not a lot of things we can do about it. Meaning, you can put somebody on antioxidants, CoQ10, oxidative stress reducers, things like that to try and help with that. If someone has like a structural abnormality within the vasculature of the testes, taking that out can certainly help if that's contributing to DNA fragmentation. There's some evidence that's very controversial that getting sperm surgically directly from the testicle may avoid some of the oxidative stress and decrease DNA fragmentation. That is a very controversial thing that you'll see reproductive urologists lean towards or lean away over time. But there's not a lot of things to do to fix it. And so the question is like, how much do you want to check those things when there's not much you can do about it?
Right.
At least, getting pregnant on your own.
Right. Wow. Thanks for explaining that. Oh, yeah. And yeah, that's really interesting, actually. And that doctors fall either way with it.
Yeah, as more evidence comes out, and in reproductive medicine, it's really complicated to get some great answers that really isolate the problem that you're looking at. So some studies will kind of lean in one direction, others will not. And so that when you get like a full evaluation, you take a full picture of things, you don't see it necessarily definitive in one way or the other. And that's why people start to kind of waffle between how can I really help somebody or not. Yeah.
And sometimes not to speak or anything right out of turn, but almost trial and error with some of these things too, is what it almost feels like.
And some treatments are more effective for specific individuals than others, and we just don't always know why.
Yeah, trying to figure out what works best. Yeah. Oof. So with families who go through IVF with pre-implantation, genetic testing, miscarriages still occur. Can you explain mosaic embryos, the limitations of embryo testing, and why a genetically normal embryo doesn't always guarantee a live birth?
Yeah. So as I was saying to you, one of the leading cause of losses is related to an embryo that's abnormal, but there's many other factors that can be involved with losses. And so we can't control all the things. From an embryo point of view, testing of the embryos is one way that we can try and reduce miscarriages by avoiding transferring an embryo that has the wrong number of chromosomes. It's called pre-genetic testing of the embryos. And specifically, we take a few cells off the outside of an embryo and then freeze the embryo. The cells that we take off, we send to a lab. That lab will then tell us how many chromosomes does each embryo have. from a from a selection of an embryo point of view, it's very helpful because I can then say to you, that embryo with the wrong number of chromosomes is not going to lead to a live birth, or it's going to lead to a miscarriage. Whereas these other ones that have the right number of chromosomes are far more likely to yield a healthy pregnancy. So pre-genetic testing of the embryos is helpful in that way to decrease the chance that you would have a loss due to aneuploidy, which is a big reason for losses. So I can reduce that, but I can't really reduce the chance that you have losses due to other factors that are either unknown or uncontrollable to us. Yeah. So I think each lab is different, but I think, in our lab, probably we can get miscarriage rates down to about 13% or so when we transfer a euploid embryo. So we can get it down, but we can't get it down all the way because there's a million other things that we don't know. Is the I don't know category that can contribute. So the idea when people come to see me with recurrent losses and they want to do IVF and test their embryos, it's a good start to really decrease the chance of a loss due to the wrong number of chromosomes. But there's other factors that I can't control, and I'm super transparent about that with people because I want you to know what we can control and what we can't. Some of this is random that I don't have control over and the patient doesn't have control over. And so some of that is that lost feeling like I can't control all of it, but it's important to just transparently know that.
Really, it is. And especially, with someone who's going through loss after loss, having a care team, a provider who is saying to you, listen, this is what we can control. This is what we can't. I'm going to be clearly transparent with you, but also I'm going to be honest and very upfront. And that's really like what we're looking for because, with trauma, we're already feeling like isolated, shut down. Who do we trust? Who's our safe space? And when we have those open, communicative, conversations with that, whoever's treating us, we feel like we can almost break down those barriers more. And we know going into this a lot more than we would if we didn't have those conversations. It's so important.
Yeah. I mean, I sort of, this is like one of the mainstays of how, we communicate with people is to say, look, these are the things to expect when we get our testing done, when we go over the testing. These are the things that I'm going to talk to you about. These are some of the things that I know and just don't know, but I'll be super transparent and we'll discuss it all together. I think that just kind of allows you to absorb the information in a more informative way.
Absolutely. I know we can't preach that enough around here. So thank you, Ryan, for that.
Sure.
Yeah. How often are uterine abnormalities like a septum, scar tissue, or fibroids overlooked on routine ultrasounds? When someone, requests more advanced imaging, when should they do that? Like a saline sonogram or MRI?
So it is part of our standard to evaluate the structure of the uterus, both with fertility. I do that with infertility patients, but also with recurrent loss patients. There are some conditions that we think are associated with losses, specifically septums for sure. But there are other conditions with abnormal development of an embryo of a uterus, or things that can change over time, like fibroids, polyps, endometriosis, adenomyosis, things like that can affect things. But so a saline sonogram is absolutely the first thing that I do. And I'm wanting to know, is there anything about the structure of the uterus that's contributing to this? Now, if someone has a septum, we're actually kind of cheering because it's like, great, I can take care of that in 10 minutes. I can do a hysteroscopy and even out that septum and return your chances back to normal in terms of losses just with that. So when someone has that, great news. I always kind of go back to the story when I was first out of fellowship and I was practicing, and I saw a patient who had a child before, but then had a bunch of losses as well. And she had a child, had a C-section, losses in a row, came to see me and said, I told them about the recurrent loss workup, and part of it was a saline sonogram to look at the lining of the uterus. She said, I've had losses. I've had all these ultrasounds with my losses. I had a C-section. They had my uterus out. They were cleaning out the placenta. Like, people have looked at my uterus. I'm sure it's fine. I said, well, let's check it out. And she had a big septum.
Wow.
So it had been missed on many ultrasounds with the losses. It had been missed on the C-section. And so we fixed, I fixed her septum, and then she went on to have a kid. And it's just like one of those things that I remember early on as a doc saying, remember this one, because these are things that are probably not the most common, but it sort of clarifies the reason for looking. And
Absolutely.
so we look.
And looking out of a different lens, right, too. So, for example, have had fibroids and cysts removed over the years. The doctors were really focused on removing those, not necessarily what it was causing with fertility or anything like that, right? Because that was their main focus when I was, getting treated for those things. And then, needing corrective surgeries and things like that. It's almost like, because then when we were trying to get pregnant and couldn't, our doctor was looking at it from a different way, an angle on everything. And it is really interesting you're saying this, Ryan, because I really think, and then, looking at lab work is kind of the same way, where if you're looking at it, is this person surviving or are they thriving for getting pregnant? It's a whole different way you're looking at things.
Yeah, I mean, it kind of makes me think of like when people come to talk to me about PCOS, right? And
Yes.
elevated male hormones, for example.
Yes.
I've got dark hairs that are growing that I have to pull or pluck, right? I've got some acne, but my testosterone levels are normal, so I don't have PCOS. Well, that's not the situation.
Yes.
You might have testosterone levels that are on the scale normal, but not normal for you. And so you have to kind of take all this stuff with a grain of salt, which is and direct it more to the individual patient to say, wait, look at all these things. This is the right pattern. Even if their blood tests are normal, that doesn't mean it's normal for them. So it just kind of reminds me of that thought.
Yes, absolutely. That individualized approach. Yeah. Oh, Ryan. Yeah. And endometriosis, it's, the silent inflammation isn't just about pain, but the inflammatory piece of it. How can that chronic inflammation affect implantation or early pregnancy, even when ovulation and fertilization are happening, especially with the recurring losses?
Well, what we know is that there are some inflammatory conditions that can lead to difficulty getting pregnant and staying pregnant. Endometriosis is a very common thing for us to be aware of, but also a very difficult thing to diagnose.
Yeah.
Part of the reason for that is the only way you can truly diagnose endometriosis is to do a laparoscopy. So you do a surgery, you look for the condition, you take a biopsy of it, and you give it to the pathologist. They look under a microscope and say, yes, that's endo. But it's really not a good way to do this. In other words, why would you take the risk of a laparoscopy when you don't need to? So in general, most reproductive endocrinologists will advocate not having a surgery and to just be aware that endometriosis may be playing a role in this, especially if someone has painful periods. But the reality is that over the years, reproductive endocrinologists have gone from doing a laparoscopy on many people to look at tubes and endometriosis to saying, why am I exposing people to risk with this surgery when I can just get through treatments that are very successful to work, whether or not you had a laparoscopy or not? So the general idea is we tend to do laparoscopies only if someone has such severe pain that it warrants a surgery. You don't do it specifically for fertility. And there's one old study that said that you would need to do 37 laparoscopies on people to have one additional pregnancy. So basically it was saying doing these surgeries are not helpful from a fertility perspective. Now, if you have a lot of pain with your periods and it warrants a surgery and endometriosis is taken back, you may get some fertility benefit from it. But the reality is we tend not to do that.
Yeah.
But in general, endometriosis and its cousin adenomyosis, which is in the endometriosis that's in the wall of the uterus, those are things that are basically hyperinflammatory conditions that can lead to difficulty implanting.
Yeah.
And there's different ways that we handle adenomyosis and endometriosis depending on what kind of treatments people are involved in, but it definitely affects implantation. It can make, even if you do implant, for example, with adenomyosis, it can make the placenta less effective at finding the bloodstream, which can compromise the growth of the baby over time. So there are longitudinal problems that can happen during a pregnancy, not just getting pregnant itself, but trying to get through the pregnancy. So those are all things that we consider when we're taking care of people with these conditions.
Wow. Wow. Yeah. And this, I mean, just to go into, after loss too, and hormones and things like that, many women, myself included, were prescribed progesterone after loss. How common is that in the, to supplement that and meaningfully to improve pregnancy outcomes?
So the way that I talk about this with my patients is to say, do I give progesterone in the second half of the cycle when people are doing any sort of treatment here? And the answer is yes. But the reason I do it is not because I know it works, but because there's not a lot of downside. So people come to me and say, my cousin had trouble getting pregnant and they were given progesterone and I had a baby and they had a baby, and so there's a lot of these associations that people have. But what people don't realize is that if someone has their progesterone checked and it's low, we don't truly know if it's low because progesterone is secreted in what they call a pulsatile way. So if you checked it over and over again over 10 hours, you get wildly different numbers. So seeing a low number is not necessarily meaning that you've got a low progesterone level. And if you truly did have a low progesterone level, it's likely because the pregnancy was abnormal, not because you're not producing progesterone. So I can give you progesterone, which fixes the progesterone level, but doesn't fix an abnormal pregnancy. So while we give it, I talk to my patients and say, look, transparently, I don't know if this is helping, but there's not a downside. If you were one of the very rare people who had an issue with making progesterone, here it is.
Yeah.
But not to say that giving progesterone fixes an abnormal pregnancy. So it's a little controversial. Some people shy away from giving it. I don't think there's really a downside to doing it. So we often will give it to people, but with the transparent angle to say, I don't know how much I'm helping, but I'm not hurting. Let's cover that as a possibility. And so that's the way I typically talk about it.
Yeah. No, and I think that's great to understand, right? Because even thinking back when I, was on it, there wasn't really any risks or long-term effects or anything like that, and I'm grateful to hear that it's still like that, Ryan.
Yeah,
so.
The only thing that you have to be aware of is theoretically it could delay a pregnancy. A bleed if you weren't pregnant, theoretically.
Oh, yes.
When I see patients, they're coming to see me for a pregnancy test at a specific time. And so if their pregnancy test is negative, we stop the medications. But if you're doing that on your own, you could delay your pregnancy, your bleed after a negative pregnancy test a little bit with it. But I encourage people to just take the pregnancy test at home if that's what you're doing. And if it's negative, stop it.
Yeah. Most of the times we're testing everything at home too, right?
Yeah.
Oh, and for the IVF, like reducing risks with miscarriage, when we're having reoccurring pregnancy losses, when does IVF with genetic testing statistically reduce that risk, and when might it not significantly improve outcomes compared to natural conception?
Well, what I would say to you is, I think the real statement is to say it's a faster time to a successful pregnancy. So it doesn't necessarily increase the pregnancy rates, but the testing of the embryos, but it does allow us to select an embryo that has the capability of a live birth faster than if we didn't do testing. So for example, if we had 5 embryos to work with and they were not tested and 2 were abnormal and 3 were normal, I am transferring an embryo one at a time based on how the embryos look, the grading.
Yeah.
And whether that embryo is normal or not is kind of random. It's not necessarily related to the grading. So I'm a 1 in 5 chance of transferring it, or 2 in 5 chance of having transferring an embryo that has the wrong number of chromosomes that is not going to work. So I would say to you, it's a faster time to a successful pregnancy because I can select an embryo that is or deselect an embryo that cannot be a baby.
Right. Yeah. Well, and it's going into it very evidence-based, based on seeing what you're able to test with the embryos and everything ahead of time.
And with this testing, really all we're testing is the number of chromosomes.
Right.
I can't tell every little single thing about an embryo.
No.
The way to kind of think about it is back to the encyclopedias.
Yeah.
That I can tell if you have the right number of books in the encyclopedia set, but I can't tell you in book 3 that chapter 2 is written backwards.
Right.
So I can't tell little details, but I could tell the main building blocks to say, look, this has the right number. Ones that don't have the right number are embryos that we should avoid.
Yeah. No, it's good to know. Thanks for clarifying that, Ryan. And down to our last one. And this is a big one. I know that I saved this for last and we already were talking about eggs a little bit, but this is what our community, we always feel like our eggs are on timers. And I know we touched on it a little bit, when looking at if we're 36, it's really 37 for our eggs because we're born with all of them. We hear about age and egg quality. Are there biomarkers beyond AMH that better predict miscarriage risk? And how do you counsel patients without oversimplifying fertility decline? I know it's a doozy.
Well, I think what I go back to when I talk to patients is biology, and I go through the whole thing.
Right.
You're born with all your eggs. So over time, there are chances for eggs to become abnormal over time. And remember, our parents' generation tended to have kids at younger ages, right? And so maybe there was less of the age factor involved, whereas our generation is a little different. And people are having babies later in life, which now introduces more egg quality issues over time. So the general idea is I can't rate someone's quality of eggs. I can't say your eggs are an 8 out of 10.
Right.
But I could say, look, your birthday is what dictates the likelihood of having more good eggs than bad eggs.
Yeah.
And one of the ways that we know all this information is not just the fact that miscarriage rates go up over a woman's age, right? That's evidence that we have abnormal embryos or abnormal eggs leading to abnormal embryos. But the other is when we test embryos to see if they're genetically normal, we have certain expectations about aneuploid rates, the rate of an abnormal embryo based on the woman's age. So at the age of 30, about 75% of beautiful blastocyst embryos are normal. At the age of 40, about 75% are genetically abnormal, even though they look fantastic. And 35 to 36 is where you have that 50-50 point. So if a woman has 6 embryos and she's 35, I'm going to say, maybe we've got 3 normals in here.
Wow.
If a woman's 40, we're starting to say a lot less. And so I think it's important to talk about some of that biology and some of the expectations. But when people talk about AMHs, I love AMHs. It's a great way of understanding your egg reserve over time. It's a hormone that is made by the cells that are around your eggs. So the more eggs you have, the more cells around the eggs, the higher the number. So AMH is a fantastic way to try and get a feel for your quantity, but it doesn't say that there's a problem with quality. So if someone has a low AMH and they're coming to see me, I am saying to you, you have a low amount of eggs. I don't know that you have bad eggs in any way, shape, or form. If someone is 40, I'm worried about their eggs. If someone's 30, I'm worried about them less. But the AMH is really more so to say, what's my reproductive longevity as opposed to my quality? So I think understanding that if you get a test, kind of understanding what it's telling you is super important. So AMH is more related to your quantity. AMH does not tell us if it's low that you're not going to get pregnant.
Wow.
I don't know if I answered your question, but
Yes, you did. You did. Absolutely. Thank you. And thank you for answering all these, questions. A lot of survivors in our community go through reoccurring loss. So, and when this happens, it's always nice when we can give them an expert who can answer some questions for them that they don't feel comfortable asking or they're not ready to ask themselves. So they give it to us. So we just can't thank you enough for that, Ryan. And I would love for you to leave our listeners with words of advice or any, little ending that you would like to.
I would say to you, if you feel like you're having trouble, to reach out to somebody. Certainly with reproductive endocrinology, there are some aspects that we don't have answers to, but many times we do have some answers, and we can certainly talk you through them. And whether or not you do something about it is a different story, but if you want to get some answers, there are things that we can do to help you avoid either difficulty getting pregnant or recurrent losses. There's some treatments that are quite effective. There are other situations where they're not, but the testing and confiding in somebody is probably the first step.
Thank you. Thank you for leaving our listeners with that.
Sure.
And thank you so much for joining us today, for sharing your expertise, your perspective, and a deeper medical understanding beyond, recurrent pregnancy loss. Conversations like this matter because they help families feel less alone and remind them that their questions, their grief, and their search for answers are valid. So thank you, Ryan.
Yeah, happy to help.
Thank you. To anyone listening who might be navigating infertility, recurrent pregnancy loss, miscarriage, stillbirth, any type of pregnancy or infant loss, please know your story matters, your baby matters, and your grief matters. Healing doesn't follow a timeline. Trauma and loss don't have a schedule. And you deserve compassionate support through every step of your journey. At Chasing the Rainbows, we provide daily support services, free, and community for families impacted by infertility, pregnancy, and infant loss, because every loss matters. If this conversation resonates with you, please share this episode with someone who may need it. And if you are looking for support, want to volunteer, donate, or host an event in honor of your baby, you can learn more at chasingtherainbows.org. Thank you for being here, for listening, and for continuing to break the silence around infertility and baby loss. Until next time, this is Cried Out Loud. Thank you.